Hi again, this is Dr. Jacobson providing you with golden advice for passing the ADEX exam. In this video, I will focus on the endodontic clinical examination. To provide you with my background, I'm a native Spanish speaker. I received my Doctor of Dental Medicine and Master of Public Health in 2015. After that, I completed a 12-month general practice residency, spent over 7 years working at community health centers. I'm a clinical assistant professor, a curriculum consultant, and an author. I'm the author of Clinical Dentistry Daily Reference Guide. This book is a one-stop resource loaded with critical information for day-to-day clinical decision-making. I wrote this book to help dental students and dentists better navigate the complexities of dentistry. Disclaimer, this video does not guarantee a passing score. In this video, I will cover the following topics. What is the endodontic clinical exam? What to expect on the day of the exam? How I prepared. The supplies you will need. The anterior root canal treatment steps, along with the posterior endodontic access steps. What is the endodontic clinical exam? A quick overview of the ADEX exam. The CDCA Reb administers the ADEX Clinical Dental Licensure Exam. ADEX stands for the American Board of Dental Examinations. This exam includes a written component and a simulated clinical examination on the mannequin, which is made up of 4 parts: the periodontal or scaling and root planing clinical exam, the restorative portion, the fixed prosthodontic portion, and the endodontic clinical exam. The endodontic clinical examination includes accessing and completing the root canal on number 8, along with accessing number 14. What to expect on the day of the exam. This exam takes place over 2 days. Here's an example of a possible schedule. Day 1, 6:30 a.m. setup. At 7 a.m., the examiners distribute folders, radiographs, and typodonts. From 8 a.m. to 3 p.m. is the restorative exam, which includes Class 2 and Class 3 composites. From 3:30 to 5 p.m. is the periodontal, or the scaling and root planing examination. Day 2, again 6:30 a.m. setup, and then you have 3 hours for the endodontic exam, and then 4 hours for the prosthodontic exam, which is the crown and bridge. How did I prepare? I read the manual front to back. I watched every YouTube video I could find on this topic. I created my own procedural checklist, practiced every procedure 6 times. And every time I practiced, I learned something new, and I added these notes to my checklist. When preparing for this exam, I wrote out a practice schedule. So every weekend I practiced everything 5 times, and then at the end, the last weekend, I had a practice mock exam, which was my 6th time practicing. So here you can see the first weekend I practiced the periodontal part of the exam, followed by the restorative for 2 weekends, the crown and bridge for 2 weekends, the endodontic portion for 2 weekends, and then on the 8th weekend I had my mock exam. The weekends leading up to the mock exam, I was practicing for accuracy, but at the mock exam, I timed myself as if it were the real thing. When planning out your practice schedule, you have to be realistic, since you're not a robot. One weekend you might be sick, and another weekend it might be someone's birthday. Make sure to practice placing and removing the rubber dam, and self-assess your work. Ask yourself, how can I improve? I learned a lot along the way, and I'll share everything I learned with you for you to succeed, so that one day your name is on the certificate. Let's review the supplies you will need. The tub, mirror, explorer, and digital clock. Miscellaneous items include gloves, shield, masks, gown, scrub cap, loops, eye protection, pens, the battery-operated digital clock, which is allowed, hand pieces, both the high and slow speed, and the motor, food and water, any medications you may need, and the operatory setup. Endo items for practicing everything 6 times from accidental.com includes the restorative typodont, the bite limiting rod for the articulator. This is so that the mandible doesn't just swing open. And then the RCT teeth for number 8 and 14. Do not bring the following to the exam: typodont, bite limiting rod, screwdriver, phones, smartwatches, plastic teeth. You are allowed to have the manual. It's an open book exam. You are allowed to have notes and drawings written in the manual. However, you are not allowed to have additional paper and notes in the manual. For example, you can have the manual. What you can do is write on the back of the pages. Here's an example of one of the back side of the pages with my drawings and procedural checklists. Rubber dam isolation supplies, including clamps, dams, rubber dam punch, frame, forceps, eye protection, 2 black Sharpies, wedgets, floss singles, scissors, and cotton pliers. I packed all of this into a 1-gallon Ziploc bag. More endodontic supplies, including hand files number 10, 15, 20, 25, 30, 35, rotary files number 25, 30, 35, 40, number 2 pencil, endo ring and foam triangle, sealer, gutta percha points, the adaptive red medium large size, torch, butane, endodontic explore, alcohol, cotton rolls, which are not photographed, syringes, 2 of them, spoon excavator, perio probe with millimeters or Williams markings, endo burr block with a surgical round burrs, diamond burrs, 330 carbide burr, Gates Glidden burr 2, 3, 4, the endo Z burr, paper points, mouth mirror, RC prep, and plugger. I packed these items into 2 Ziploc bags and fit everything into a plastic container. And please don't make the mistake I made of leaving your supplies in your car. My car was broken into, and I lost $16,000 worth of supplies, including my loops, the hand pieces, the plastic teeth, the typodont, etc. So don't make this mistake. Now I'll review the procedural steps for the anterior root canal treatment on number 8. First, read every word of the manual. I will review with you all of these steps, including measure and draw, isolate, access, clean and shape, and obturate. First, measure and draw. Measure tooth number 8 and subtract less than or equal to 2 millimeters for the working length, which is WL, and then draw the access with a pencil. The length of this tooth is 25 millimeters. I subtracted 1 millimeter for a total of 24 millimeters. If your working length is less than 2 millimeters from the apex or extruded, you will fail. Then I measured the clinical crown, which is 10 millimeters. With a pencil on tooth number 8 on the lingual surface, draw the triangular shape access. Make sure you're 3 millimeters away from the incisal edge, from the mesial and distal, and 5 millimeters from the CEJ on the lingual. Isolate the tooth. What I recommend is holding the rubber dam over the teeth, and then mark with a Sharpie where the teeth are located on the incisal edges of 6 to 11. Punch the holes, stretch the holes over teeth 6 to 11, and then place wedgets. Wedgets are like rubber floss. and then place the frame. Make sure the patient can breathe out their nose, so make sure it's not covering their nose. Don't do this. As you can see in the photo, the rubber dam is covering the nostrils on the simulated patient. So make sure to cut the excess rubber dam or fold it underneath. Access. This is the drawing I made based off of the manual, and I drew it on the back page of the manual so that I could refer to it during the exam. For the access, make sure that the top of the triangle, or the base of the triangle, is greater than or equal to 2 millimeters from the incisal edge of the tooth. Make sure the apex of the triangle access is greater than or equal to 3 millimeters from the lingual CEJ. The widest portion, mesiodistally, should be less than half the lingual surface. Be sure that you're greater than 1 millimeter from the marginal ridge, both on the mesial and distal. And when you prep this, make sure you start conservative. Keep at least 3 millimeters from the incisal edge, the mesial, the distal, and 5 millimeters from the lingual CEJ. Begin with the 330 carbide burr by creating the access shape into dentin. With a round surgical burr perpendicular to the lingual surface, drill until you reach the pulp chamber, and then reposition the round surgical burr along the lawn axis and drill further. The reason you reposition is to avoid perforating out the facial. Here you can see teeth 6 to 11 are isolated, and I've drawn the access shape on number 8 lingual. Here I'm positioning the burr perpendicular to the lingual surface of number 8. I've now accessed number 8 lingual, and here you can see it's filled with red wax. Up close. Soak a cotton pellet with alcohol to dissolve the pulp tissue. The pulp tissue, which is red wax, can then be removed with a spoon excavator, and then repeat by soaking the wax again with alcohol. Before and after removing the red wax, which simulates the pulp tissue. For the access, you need to remove the pulp horns. So check with the Explorer to see if it catches. Smooth with a diamond burr if it does, and smooth all the walls with a diamond burr. Imagine if you could see through the tooth from the side. So let's say you're looking at the tooth from the distal surface. You're looking through to see the shape going from where you access the tooth into the pulp chamber. Insert your Explorer, sliding the Explorer up until the Explorer comes out of the access. The movement should be smooth without any interruptions or catches. Per the manual, your access over the pulp chamber must allow for the pulp horns to be fully removed for complete debridement of the pulp chamber and straight line access. So again, picture looking through the tooth from the side. If you insert your Explorer and you pull and it catches, that means you haven't fully opened up your access to allow for complete debridement of the pulp horns. Here the dotted lines show you where the access should be located for complete debridement of the pulp chamber. Be sure to refer to the manual, measuring the size of your access and the distance to the incisal edge, the marginal ridges, and the lingual CEJ. Now it's time to clean and shape. For this, you will use hand files, Gates Glidden burrs, and rotary files. Hand files and rotary files come in different lengths. In this photo, you see 21 millimeter, 25 millimeter, and 31 millimeter length. When we measured the tooth, it was 25 millimeters long. So for this tooth, I would use a 31 millimeter long files. Begin with hand file number 10, reaming, where you're using a clockwork motion going clockwise and counterclockwise while filing up and down to the working length. Irrigate with alcohol to soften the wax and recapitulate with the number 10 file, making sure that there are no debris plugging up the apex so that you can access all the way down to your working length, which we determined was 24 millimeters. After using hand file number 10, follow the same steps with number 15, number 20, and number 25 hand files, always recapitulating with the number 10 hand file. Also, something I learned while practicing on these plastic teeth is to be sure you have extra needles, because when you're inserting the needle and irrigating with alcohol, what happens is that wax will block the tip of the needle and occlude the needle, preventing any alcohol from coming out. So you'll probably have to change your needle a few times. The Gates Glidden burrs are really useful for removing the dentin shelves. So begin with Gates Glidden burr number 2. Insert it in the access and then press it against the lingual surface as you come out. And then repeat this but against the mesial surface and the distal surface, removing the dentin shelves. Then you can go up in size to the number 3 and then the number 4. This is what I mean by the dentin shelves. I drew it in here, but if you're looking inside of the access, you'll see some excess dentin that's in your way on the lingual, on the mesial, and the distal surfaces. Up close. This can be easily removed with the number 2, 3, and 4 Gates Glidden burrs. With the rotary files, I recommend inserting it to working length, stepping on the rheostat, and pulling out while brushing up against a wall, let's say the facial wall. Once you remove the rotary file from the tooth, wipe the flutes to remove any dentinal debris with an alcohol wipe. And then repeat until there's no more debris. Then insert the rotary file and repeat, brushing against the distal wall. Follow the same steps. Repeat, brushing against the lingual wall. Follow the same steps. Insert and brush against the mesial wall, repeating these steps for files number 25, 30, 35, and 40. When practicing this, I found that it was helpful to hold the handpiece with my dominant hand and to use my non-dominant hand to also hold the handpiece to control it, to prevent the rotary file from being pulled or sucked down too far apically into the tooth. Then check if the number 35 hand file will reach working length, which we determined was 24 millimeters. Now it's time to obturate. These are the steps: dry with paper points, try in the master cone, cut the master cone, apply sealer, insert the master cone, sear off any excess, and clean out the pulp chamber. First, dry the canal with the paper points. Measure the master cone to 24 millimeters and crimp it while you squeeze it with the cotton pliers, and insert the master cone to working length. Ideally, you want to have tug back, meaning it should fit snug at 24 millimeters, which is your working length. If there's tug back and it's too long, meaning it's going too far down beyond 24 millimeters, I recommend slicing the tip of the gutta percha. If you have tug back but it's too short, so it's less than 24 millimeters, you need to go back and clean and shape by instrumenting more. And check with the number 10 hand file beyond the working length to remove any debris that are blocking your way. If you insert the master cone and it comes off looking wrinkled at the end, then the canal is too small and you have to instrument more. Once your master cone fits perfectly, so you have tug back and it reaches the working length of 24 millimeters, then cut the master cone by 10 millimeters. Remember when we measured the clinical crown? That was 10 millimeters. Use very little sealer and paint the walls of the canal with sealer on a number 25 hand file, and then dip the master cone in the sealer. Insert the master cone to working length. Use the torch and heat your endo plugger. The tip will turn orange and sear off any excess gutta percha. The gutta percha must be less than or equal to 3 millimeters below the lingual CEJ, per the manual. Clean out the pulp chamber, as there will be debris, possibly excess gutta percha, excess sealer, pencil marks, using alcohol with the cotton pellet and the spoon excavator. 2 cautionary tales for you. For the number 8 root canal. Someone I knew, while they were using the hand file and filing up and down in the canal, nicked the enamel. Here you can see where the enamel was nicked. When the examiner was grading this, the examiner used the perio probe to measure how far the access was from the incisal edge. The examiner measured from the top of where the enamel was nicked to the incisal edge, stating that the access was too large and that there was less than 2 millimeters from the incisal edge. This resulted in a fail. The distance from the incisal edge to the access must be greater than or equal to 2 millimeters. The student failed the number 8 and had to repeat the number 8 and 14 endodontic clinical exam. The second cautionary tale is about another dental student that completed the number 8 root canal. There was a speck of sealer that extruded beyond the apex of the number 8. Therefore, the student failed. Be sure that the gutta percha is less than or equal to 2 millimeters from the apex and that nothing extrudes beyond the apex. Procedural steps for the posterior endodontic access. Read every word of the manual. I recommend drawing tooth number 14 along with all the criteria that you need to follow. Here are some more drawings of the criteria. For the posterior endodontic access on tooth number 14, you will isolate the tooth, draw, access, remove wax, and check for straight line access. Isolation. For the rubber dam isolation of tooth number 14, I recommend isolating tooth number 12 to 15 so that you have more working space. Hold the rubber dam over the teeth and mark with a Sharpie teeth number 12, 13, 14, and 15. This way you know exactly how far apart they're spaced. Then punch holes. Stretch the holes over the teeth. Clamp tooth number 15 with a W8A clamp. Place the frame, and again make sure the patient can breathe out of their nose. Quick disclaimer. These photos are taken on a tabletop for better visualization, but for the exam, the tooth is on a typodont in the simulated patient's mouth with rubber dam isolation. With a pencil, mark a dot on the central pit. Here's an up-close image. For the access, position the simulated patient's head parallel to the floor. Orient the surgical round burr so that the shank is perfectly parallel to the lawn axis of the tooth. Start at the central fossa. Drill until you feel the drop into the pulp chamber. Make sure you are inside the pulp chamber before widening the access. Check with the probe to make sure you're in the pulp chamber. Here you can see the simulated patient's head is parallel to the floor. Here the shank of the burr is perfectly parallel to the long axis to the tooth. Another way you could think of it is the shank of the burr is perpendicular to the occlusal surface. Drill until the burr drops inside the pulp chamber, which is filled with red wax. With the pencil, mark the following reference points so that you can use these to measure the distance to your axis. Mark the marginal ridge, the tip of the mesial buccal cusp, tip of the mesial lingual cusp, tip of the distal buccal cusp, and mark the distal oblique groove. When widening the axis, be sure to use endo-safe burrs or non-end cutting burrs so that you're not drilling into the pulp floor. Use these to widen the axis, but caution not to over widen the axis. You can use an endo-Z burr and tilt the burr to remove the undercuts in the pulp chamber without widening the axis at a speed of 10,000 RPM. And then with your perio probe, measure the distance of your axis to those reference points, and then refine the axis. Here's an up-close image of a safe end or non-tip cutting burr. Widening the axis, widening more, and measuring. The distance must be greater than or equal to 2 millimeters from the marginal ridge, greater than or equal to 1 millimeter from the distal oblique groove, greater than or equal to 1 millimeter from the mesial lingual cusp tip, greater than or equal to 1 millimeter from the imaginary line drawn from the buccal cusp tips. The axis widened even more. Remove the wax from the pulp chamber with cotton pellets soaked in alcohol and with a spoon excavator. Soak the cotton pellet. Transfer it with your cotton pliers and bury it inside of the axis. Let it soak for a few seconds. Remove the cotton and begin removing the wax with a spoon excavator. Check for straight line access with the Endo Explorer to the distal buccal, mesial buccal, and palatal canals. The Endo Explorer should not touch the walls. Remove buccal and palatal dentin shelves with the number 25 hand file to the depth of 15 millimeters and with the number 25 rotary file to 15 millimeters. This way the examiner can easily view all 3 canals. This is tooth number 14. In red, I've drawn both the buccal and palatal dentin shelves that you need to remove. Checking for straight line access with the Endodontic Explorer, making sure it's not contacting any of the walls. Checking for straight line access to the mesial buccal canal and straight line access to the palatal canal. Check for undercuts with the Explorer from the pulp chamber out the axis. Insert the Explorer. Slide the tip of the Explorer up the internal walls until you come out the axis. Remove any undercuts with the Endo Safe diamond burr, tilting the burr so that while you're reducing these undercuts and eliminating them, you're not widening the axis. If you widen the axis too much, you could fail. With the alcohol-soaked cotton pellet, make sure there's no wax in the pulp chamber. You should have greater than 10 millimeters from the buccal cavo surface to the floor of the pulp chamber. Insert your perio probe and measure the depth to the pulp floor. Lastly, remove the pencil marks with the alcohol. As a reminder, in this exam, the simulated patient, which is a mannequin, is treated as if it were an actual live patient, meaning you must follow proper infection control protocols and ergonomics. Using proper ergonomics means relaxing your shoulders and arms and checking if the patient's mouth is at or below your elbow. If your chair is too low and or if the patient is too high, your hands and wrists will be located higher than your elbows and you'll be in the praying mantis position. Patient positioning depends on whether you're working on the maxillary arch or the mandibular arch. For the endodontic exam, you will be working on teeth number 8 and 14, so the patient should be supine or laying flat with the chin up. For the restorative part of the exam and the scaling and root planing, you will work on the mandibular arch, so the patient should be semi-supine with the chin down. Practice and good luck on the exam. Check out my website for more student resources at williamjacobson.net. On my website, you have access to resources. Here, I continue adding documents with advice, such as job search advice, pros and cons of working as a dentist at community health centers, post-dental school requirements for your dental license, post-operative instructions, book and app recommendations, Dental Assisting 101, what to do when a patient refuses, treatment or diagnosing, customer service, and other advice. If you're interested in learning more about endo, in my book, Clinical Dentistry Daily Reference Guide, I have an endo chapter where I cover diagnosis, types of tooth fractures, the American Association of Endodontists Case Difficulty Assessment, when to refer, dental materials to use during root canal procedures, the rules of symmetry, teeth with relevant information about access and working lengths, procedural steps for pulpotomies, pulpectomies, non-surgical root canal treatments, follow-up and internal bleaching, visit note templates, clinical pearls, and more. The book is available on Amazon.